Welcome to the Special Operations Medical Association podcast series on prolonged field care. Any opinions contained in these podcasts are those of the authors alone and do not reflect U.S. Army, DoD, or U.S. government opinion or policy.
All right, so in this podcast, this is the second in a series on pharm. I've asked Brad to go into the concept of MISMAID. And MISMAID is just an acronym that anesthesia providers use prior to putting a patient to sleep. It's kind of their mental checklist they go through in the pre-op environment where they make sure their anesthesia machine is working well, their suction is working, the monitor is doing its thing, the IVs are patent and they got enough drugs to do the case, and they've got all their airway stuff laid out ahead of time. Well, obviously that's not our environment, but it's still a helpful acronym. And Brad's going to explain this to us kind of in his words of how he thinks it relates to our environment. In the show notes on prolongedfieldcare.org, you're going to find a document that's just titled MISMAID. And what I did here is I went through a lot of what Brad has said and some other anesthesia providers and basically put down recommendations for what MISMAID could mean in your aid bag or in your aid station when you're deployed. The document has a much lengthier explanation of all this stuff. So Brad's just he's going to go through the wave tops of what this is so you can have an understanding of what we're really talking about here. So there's two ways we're going to use this. The first is in what gear to bring with you. And the second is running your team through a similar pre-op checklist. And I detailed that in the show notes where I put actual, example verbiage of what you would be saying to your guys before you sedate somebody. Say you're going to set a really nasty fracture in the remote setting. So you're about to push a bunch of ketamine on this guy and maybe some fentanyl with that and some Versed. And there's a potential that, he might have a reaction that you weren't expecting. So we have to be prepared to ventilate the guy. We have to be monitoring his airway at all times. We have to be prepared in case he does throw up. We got to have a plan for that. We have to have a plan for a rescue airway should we need to put one in. And we got to check our IV access to make sure that that's patent. And we got to make sure that we have more medication on hand if the procedure takes longer than expected. So that's just an example of how you can use MISMAID as kind of taking your team through what they're going to need to do to help you out. All right, so without further ado, here's Brad explaining MISMAID.
In the anesthesia world, MISMAID is one of the first acronyms that's given to you for you to set up your area to be able to have a check sheet to say, I'm ready to put somebody to sleep safely and effectively. As I've approached, the austere environment, whether from an evac or from a surgical side or just point of injury care, is to tailor that MISMAID algorithm into what I'm carrying. An example of that is the M stands for machine. Well, obviously in the hospital, we're talking about the actual anesthesia machine, but really what it stands for is a way to give a positive pressure breath, all the way down to having an ambu bag of the point of where I can actually ventilate somebody in a bad situation. The S is suction. Powered suction obviously is the best, like in the hospital, but we may be all the way down to having some type of a turkey baster suction or easy suction, some way to suck out the airway in case they do aspirate, that we can try and protect their airway the best that we can. And then we're talking about the next M is monitors. And again, in the hospital, you've got pretty much the world as far as monitoring systems, whereas in the field, like I've always said, and also in the hospital, you as the treatment provider are the most important monitor. Don't ever get lost in the sauce of technology, the fact that you can look at somebody and know something is wrong. But then building up from there, personally, I like having a pulse ox. It's kind of my bare minimum because it's giving me the most bang for my buck. It's giving me an O2 saturation, and it should be giving me a heart rate as well. And then just kind of working your way up there for monitoring. End-tidal CO2, now that we have the the small Catno checks is excellent, especially if you're going to have any kind of a ET tube or crike in somebody. It's incredibly important. Temperature, blood pressure. The A stands for airway, and that basically means that you're prepared to secure a patient's airway in whatever environment that you're in. So, if you have the ability to do laryngoscopy, then having, everything that you need to do, the ET tubes, obviously, as well as the right blades and everything works along those lines. And always having some type of rescue backup, whether that's a LMA or a King LT, or like I've showed you guys before, just having a bougie to give you an option in case things go wrong, but then also obviously having a crike kit and the ability to do that as well. After that, the I stands for IV or IO. One important thing I think to note is that all the drugs that we've been talking about giving can be given IO just like they can be given IV. But you got to have some sort of access, going back to what we were talking about before, how doing things IM is really not an optimum way to do sedation type protocols that we're talking about. So having some sort of access down that road. And then finally, D is drugs, and that's just going to depend on your toolbox. But the most important thing, like I've always said, if you're going to put a drug in your box, you need to know everything about it. It better not be an enigma to you, because whenever things go wrong, that's not the time to try and start breaking out a book and trying to read about it. You need to know what it is, what you're using it for, what the dosages are, and you need to have experience, using that in an environment before you get into a serious situation.
All right, so that was a brief intro to Mismade. And like I said before, go to prolongedfieldcare.org and download the show notes that go with this so you can read in detail everything we're talking about. All right, so before we wrap this thing up, I want to direct you to the emcrit.org website. If you haven't checked that out, I highly recommend you do that. There's lots of really good podcasts on there. 2 of them are referenced in our Mismade paper. So there's a talk on BVM ventilation that's really, really good and talks about the 2 thumbs down technique. So if you don't know what that is, check out the podcast and they'll explain it to you. It's actually a video podcast that goes along with it. So check that out. And the other issue is on the pulse ox. Look up the talk entitled Oxygen Physiology on there as well. Really good talk. Talks about the lag time between what you're seeing in a fingertip pulse ox reading and what's actually happening in the body. And it's something like 3 minutes. So it just really good talk that talks about the limitations of pulse oximetry. And we're not saying to throw out your pulse ox, but we are just saying you need to know your equipment and know its limitations. All right, the last thing I want to highlight on the show notes are at the very end when we talk about the drugs portion. I want to highlight the sample math we did on there about how you would determine how much ketamine you would need to bring on a deployment. And what we've done there is just made an example, backwards timeline for your evacuation. So basically, if it takes you, 36 or 24 hours or whatever to actually get somebody out of the country that you're in, you're going to take your 250 cc ketamine sedation drip bag, which gives you about 5 hours of sedation, and just run that into the number of hours that you need to sit on somebody for. And that's going to let you know. The example we came up with there was pretty reasonable, and it's like 9 vials. So I think people have this idea that they're going to need cases of medication to keep somebody sedated, and that's just not the case. You are going to need a pretty good amount of meds, but it's nothing ridiculous. And this way, if you have the math all laid out when it comes time for you to draw the medications, and some people start to raise some eyebrows, and they're like, why do you want 15 vials of ketamine? You can say, because this is my evacuation timeline, and if I have to keep somebody sedated with an ET tube in their throat, it's going to require this much ketamine, and I like to have a couple vials in reserve. And then you can't really argue with that. So again, what we're trying to do is give you tools to get the equipment that you need when you deploy in the PFC setting.